So this presentation title is Diabetes and Periodontal Disease. And basically the presentation is an overview for the practitioner. My name is Melissa Brown and I am a general dentist. So today's presentation will be providing you with guidelines for identifying clinical signs of periodontal disease. It will also review the close relationship between diabetes and periodontal disease. The objective of the presentation is to provide you with information that you can provide to your patients. So first we're going to start by just going over diabetes. So diabetes is a group of diseases that involve too much sugar in the blood or elevated blood glucose. There are the three main types that you're aware of. Type 1, which is formerly juvenile diabetes, and that is an autoimmune destruction of the beta cells of the pancreas. And this can lead to an increase, an insulin deficiency and increased blood and urine glucose. The second type, type 2, is the most common form, and you may know this as adult onset diabetes. Type 2 is a peripheral resistance to insulin, impaired insulin secretion, and increased glucose being made in the liver. The third main type is gestational diabetes, and that is with our pregnant ladies where they have a glucose intolerance during their pregnancy. And then there are some other specific types, but we won't mention those today. So next we're going to discuss the gingiva, the overall smile that you see when you see a patient. The gingiva is the tissue, the skin, that covers the bone and a portion of the teeth. In regards to color, there are two variations of color. The first is coral pink, which is the most common presentation, and the second is pigmented gingiva, and that's commonly seen in people with a lot of melanin in their skin, so a lot of people that are black. In regards to texture, the gums should have an orange peel appearance, and this appearance is called stippled. So when we take a look at both images on the screen, the one on the lower left, that is the coral pink presentation, and then the little tiny dots that you see above the two front teeth, that is that orange peel texture, the stipple effect. The image to the lower right, you see that the patient has a darker colored gingiva, and that is the melanin from the patient's skin. And this is just a variation of normal. It doesn't mean that something is wrong. And a lot of times patients will ask if there's anything they can do to change the color of their gums, and the answer is no. So now we're going to transition into the relationship between the diabetic patient and gingival conditions. So I'm going to be going back and forth a little bit about A, the gingival conditions, and then B, how diabetes is related to these conditions. So here's a quote, and this quote is from the American Academy of Periodontology. And they found that uncontrolled or poorly controlled diabetes is associated with an increased risk of periodontitis. And in the presentation, I'll be kind of referring to periodontitis as periodontal disease as well. They're the same thing. So we're going to start by reviewing the gingival conditions. So on these next few slides, I tried to color coordinate it. So green, of course, is going to be representing health. Yellow is the intermediate stage, and that's going to be gingivitis. And anything that's in red, that is periodontal disease. So I didn't put it on here, but green is health. Then we get into the stage that is gingivitis. So a lot of times when a patient hasn't had a cleaning in a while, they have what's called gingivitis. And if you see the commercials on TV, they'll tell you that if you purchase this product, it will reverse gingivitis. Gingivitis is when we don't have any bone loss. Mainly, it's just some debris on the gums and on the teeth that cause the gums to turn red and maybe slightly bleed. Once the patient has their dental cleaning, they go back to the health stage. So gingivitis is reversible. Now, in some patients where the gingivitis is prolonged for a long time, they start to get into the stages of periodontal disease. And we have different stages of periodontal disease. We won't discuss those in detail today, but when the patient comes into the dental office, that's when we kind of diagnose and pinpoint where they are in their stage. Periodontal disease, unlike gingivitis, is irreversible. So once the destruction happens, We can try to maintain health in that patient, but we can never get them back to that normal healthy stage where their bone was before the destruction of the disease. So going into these conditions, we're going to start with chronic periodontitis. Chronic periodontitis is the most common form of periodontal disease. It's mainly in adults, and it's usually when patients have a lot of plaque, that sticky film on their teeth, and calculus, which is also referred to as tartar. Chronic periodontal disease is kind of like the name suggests. It is a slow to moderate rate of destruction. Then the second type is the aggressive periodontitis. This is rapid, and usually, unlike with the chronic patient, aggressive perio is with a patient that is otherwise healthy. So this person lacks the plaque and the calculus that the chronic periodontal disease patient has, and usually with aggressive, it's a family history. Aggressive is also usually between patients between the ages of 10 to 30 years old. And then there's some other forms of periodontal disease, but we're not really going to talk about those today. The image on the screen shows two teeth. The one on the lower left, you'll see that this long instrument here is like a little tooth ruler. And we have the same on the second image. This ruler has different little indentations on there, and we read those, and that allows us to see where the bone is in relationship to the tooth. So this first image is of healthy gums. You can see that the gums around the teeth are the coral pink color. You can see that this little tan area is the bone supporting the tooth, and the bone seems to be at a very high height. And also when you look at the ruler doesn't sink all the way down. Okay, so that is health. The second image, you see that the gums have kind of turned like a red color for inflammation. We can notice that that tan area of the bone is starting to recede away from the tooth. And you also see that the ruler that was in that first image has actually slid down the neck of the tooth, and the reading on this probe is larger. Okay? And that is how we determine clinically periodontal disease. All right, so bacteria in the mouth live together in colonies. The bacteria makes a sticky biofilm, and the biofilm is called plaque. Plaque is where the bacteria live. The bacteria produce acid, and the plaque holds the acid against the teeth. So you can imagine that if a patient has a lot of acid, that they have an increased risk of tooth decay, also known as cavities. And they also have an increased risk for poor gingival health. So plaque is the sticky bacteria on the tooth, and that is the primary factor also for periodontal disease. We have health that goes to gingivitis. From gingivitis, periodontal disease. Gingivitis is reversible. Periodontal disease is irreversible. As a summary again, the chronic periodontal disease is in some adolescents, but usually it's in patients that are 30 years or older. And then some areas of the mouth progress a little faster than others. Overall, periodontal disease is not caused by age, but the longer the patient has that chronic plaque and tartar on their teeth, the more prone they are for destruction. So there are some risk factors for periodontal disease. We have the negative microorganisms, that bacteria, that is the cause. The host, the patient's mouth, is what makes them susceptible to the disease. Environmental factors, particularly smoking, is the most important factor. Systemically, diabetes has a very important role. Okay? And so we break it down a little bit here. So the higher the risk of, there's a higher risk of periodontal disease with patients that have diabetes than patients that do not have diabetes. If a patient has controlled diabetes, they have the same risk for getting periodontal disease as a patient that does not have diabetes. And then thirdly, diabetics that get the proper treatment for periodontal disease, it is possible for them to maintain a normal mouth. And then some last risk factors: nutrition, a patient's socioeconomics, bleeding when we measure the gums, a patient's genetics, HIV and AIDS. So now I'm going to go ahead and talk about some of the clinical presentations and some of the symptoms that patients may present when they have both diabetes and signs of periodontal disease. And in this case, we're going to be talking about poorly controlled diabetes. So the first thing is dry mouth, and that's called xerostomia. This is actually a symptom that the patients present with. So this is not something we diagnose. We can look in the mouth and say, oh, it looks dry, but sometimes patients will say, this is normally how my mouth is. For dry mouth, patients usually come in and they'll say, my mouth feels like a desert. And that's how we say, okay, they do have the symptoms and the feelings of the dry mouth. You can't see it, but the saliva does have an increase of glucose. And then poorly controlled diabetes puts patients at risk for bacterial, viral, and fungal infections. So this image here is thrush, which is a candida infection, a fungal infection of the mouth. Some other complications of poorly controlled diabetes: the patients have poor wound healing. So for instance, if you took a tooth out on a diabetic patient that has uncontrolled diabetes, they might heal up at a slower rate than someone who does not have diabetes or someone who has controlled diabetes. These patients have an increased risk of tooth decay, and you can see that on the image. You see the little brown areas towards the left on that tooth. Those are areas of tooth decay. Gingivitis and periodontal disease. Patients can have abscesses, and patients also may feel that their mouth has a burning sensation, burning mouth symptoms. These images here are images that you may see in patients, or you may know somebody who has the presentation like these photos. Okay? This is how untreated chronic periodontitis looks, whether the patient has diabetes or not. So usually you'll see a lot of plaque, that sticky bacteria on the teeth. You may also see calculus, that tartar above the gum line. And this first image on the top shows that. You can see that the orangish color here, that is the tartar, the calculus buildup. And then the slightly tan underneath the tartar is the sticky plaque. Patients have gingival inflammation, so you definitely see that we don't have that coral pink appearance. We also have lost our orange peel texture, the stipple effect. These patients have blunted gingiva that looks very, very inflamed. Periodontal disease is usually painless, but patients will usually have symptoms that bring them into the dentist. Otherwise, most of these patients will probably continue to go without going to the dentist because it doesn't hurt and they don't know that they have it. So sometimes patients will come in and they'll say that their gums bleed when they brush or their gums bleed when they eat. A lot of times they'll say that they have bad breath. They'll say, I do everything I can, I have Listerine in my back pocket, and no matter what, I still have this odor in my mouth. Patients will sometimes get spaces between their teeth, and that's because the bone is receding away from the tooth. And as the bone recedes and the gums kind of shrink away, their roots can become exposed. So this image here, you can see that the patient is missing some of their gums. You can see the long aspects of the teeth here. Those are the roots that are exposed. And then if you look closely in between each tooth, there is some tooth-colored bonding. So this dentist has bonded these teeth together to keep them from moving. So now we're going to go into the diagnosis and the treatment aspect of periodontal disease, especially pertaining to the diabetic patient. These brochures are brochures that we order from the American Dental Association, and they're very, very helpful because they have great pictures and easy summaries that patients can read and understand. We have all three at our office, but the one that I like the most is the scaling and root planning, the one to the right, because this one just has an overall summary of the other two brochures as well. So the patient comes to the dental office. The dentist and the dental hygienist, we're going to review the medical history. We want to see what kind of systemic conditions the patient has. We also go over their dental history. We want to know if they're always getting teeth extracted. We want to know if they get cavities often. We do our oral cancer screening. We chart their hard and soft tissue. And then what we do is we measure around each tooth to see if they have those little pockets that we discussed earlier. And that is using the periodontal probe. And I'll go over the probe in just a second. And then lastly, we take a look at the x-rays. And as you can see in this image to the lower left, this patient's bone is kind of sliding around the tooth here. Okay, and when you're looking at a patient, you can't see this bone loss because it's covered up by the gums. So that's why we measure. This is the inside of that scaling and root planning brochure from the American Dental Association. And it's very helpful for patients because it kind of just breaks down the diagnosis and the treatment. So starting with the image to the left, you can see that we have the little instrument going next to the sides of the teeth. The numbers 1, 2, and 3, so 1 to 3 millimeters, usually indicates health in a patient. When we start to have a lot of 4s in the mouth, or if we have 4, 5, 6 and above, that lets us know that the patient has deep pockets and they have periodontal disease. So it's a mixture of looking clinically and on the x-rays. Then the x-ray image, the one in the middle, you can see that there is a red line that indicates the bone level. So on the very first image, you can see that the red line is on a high level of the tooth. That patient has a lot of bone. The second image, the red line has gone down significantly, and that indicates where the bone is located. So you can imagine if we put that little instrument right next to the side of that tooth, the instrument would slide all the way down until it reaches that bone level. Without the bone supporting the tooth becomes loose. And sometimes patients have to get teeth extracted even when they don't have cavities because they can have a periodontal abscess or a lot of mobility on that tooth. So for treatment is pretty straightforward. The patient is numb. And patients really enjoy being numb because a lot of times they have a fear of the dentist. They haven't been in a long time. Their gums bleed easily. Their gums hurt when they touch them. So they prefer being numb because they don't have to feel anything. We take instruments, and instead of just focusing on the top of the teeth that you see above the gum line, we use the instruments to go underneath the gum and to remove all that tartar and buildup and bacteria in the areas that the patient cannot reach with their toothbrush or their floss. The prognosis of our treatment for periodontal disease really depends on the patient's motivation and the patient's compliance. So just a summary, scaling and root planing, which is the deep cleaning, is not the same as a regular cleaning. Patients often say, I want the cleaning that my insurance pays for. My insurance pays 100% for 2 cleanings a year, and that's all I want. Well, when a patient has periodontal disease, they no longer qualify for the regular cleaning. The standard of care is to treat the disease, to go underneath the gum line to stop that progression of the bone loss. In dentistry, we cannot grow bone back in the mouth. We can build it back in, but growing height is unpredictable. A few definitions. So a prophy is the technical name for a regular cleaning, and that's when we remove the plaque and the stain and that calculus tartar from above the tooth, from above the gum line, the part that you see of the tooth. Then the scaling and root planing, often referred to as the deep cleaning, is all of the above for the prophy, plus we're taking the instruments and we're going below the gum line in those areas with the deep pockets. Then oftentimes we go over special medicaments with the patient to help with the bacteria, and also if there's an area that we just can't seem to get healed, we may have them go to a specialist, a gum specialist, and the gum specialist may recommend a surgery to that site. So this is a before and after photo. The image on the left, you can see all that tartar buildup on the backs of this teeth. This is the lower anterior arch of this patient. So this right here is their bottom lip, and then these are their lower anterior teeth. You can see the heavy staining on the back of these teeth, of course the tartar, and you can see that the gums are inflamed. The image to the right, you can see how the gums have cleared up significantly. We don't have the inflammation. The calculus is gone, and you can actually see in between each tooth, and the staining was removed. So now we're going to go a little bit more towards the diabetic patient. So just like the physician, we are interested in knowing their diabetic values. So we particularly pay attention to the hemoglobin A1C, and that's a factor that we consider when we're planning their treatment. Hemoglobin A1C measures the long-term level of hyperglycemia. In dentistry, if we think there are signs of diabetes and the patient is unsure, or if a patient presents with diabetes that is uncontrolled, we gain permission to contact their physician to get these values if the patient doesn't know them. So step 1, we consult the physician. After we get the A1C value, we kind of take a look and analyze their test results. If the patient is between 4 to 6%, that is considered normal. If they are around in the 7 range, that's good. 7 to 8 is moderate, but anything over 8% means that the patient needs to improve their diabetic health before we can begin our dental procedure. After we do that, we want to clinically measure their gums, we want to look at their x-rays, go over everything with the patient, and determine the type of periodontal infection that they have. After that, we teach them about oral health. We want to get all of that stuff off of their teeth. We do a debridement so that we can see better. And then, like I said, if the A1C is looking good, then we can go ahead and start with that scaling and root planning. If it's not good, then what we do is we wait for them to improve before we start treatment. So your role is actually very imperative to patients. And so what I'm going to do is I'm going to give you some pointers to kind of point you in the right direction in terms of how to discuss this topic with patients and how to get them proper care. And so don't really expect you to be in their mouth, but if you'd like to look, that's fine. So these are some of the topics that I think might be helpful for you. So if you think the patient has diabetes and you're not sure, you can refer them first to their doctor for testing. In their mouth, if you're talking to them and you see clinical signs of poor oral hygiene, or if the patient knows they have periodontal disease, or if you know the patient has diabetes, you can refer them to a dentist. Referring to a general dentist is fine, and if we get in the mouth and determine that it's more involved, we can refer them to the gum specialist if we need to. And the gum specialist is called a periodontist. Okay. You can also ask when the patient had their last cleaning. You don't want to say, when was your last dental visit, Ms. Jones? Because Ms. Jones may only go to the dentist to get her teeth pulled. She may have never had an evaluation of her gums. You want to hold your patients accountable. So you want to say, Ms. Jones, when you come back to see me, I'm going to be asking you about your dental visit. I want to know specifically what did they find and how we can help to get that treated. So be sure, Ms. Jones, to take some notes so that when we see each other, we can discuss that further. You want to have literature available, especially if you're not very familiar with periodontal disease, and you might be a little shy about discussing it. If you have a brochure like those ADA brochures, you can say, Ms. Jones, hey, quick thing, looking in your mouth today, it looks like you may have something similar to this photo here. I want you to go see your general dentist, and let's see what we can come up with and see if we can find a diagnosis for you. It's helpful to have a list of providers in your neighborhood, even providers that are community health centers, because sometimes they can see patients that have limited resources, and patients can receive care on a sliding scale fee. And then lastly, you want to tell your patients the relationships between diabetes and smoking, and diabetes and periodontal disease, especially uncontrolled diabetes and periodontal disease. And all you really have to do is tell them, Ms. Jones, you are at risk of losing your teeth. Ms. Jones, you have a gum infection. And people respond to hearing the word infection. So this is just a summary brochure that I found online, and it really just kind of talks about the statistics of periodontal disease, some of the causes like we discussed, smoking and genetics, some of the effects, the bone destruction, the tooth loss, diabetes, and then the recommendations of brushing twice a day, flossing, and visiting the dentist. So, as a summary, the mouth and the body are connected. If you notice any signs of inflamed gums or a lot of tartar on a patient's teeth, or if you notice bad breath, or if your patient comes to you and reports different symptoms of like bleeding gums, tooth mobility, or pain, don't hesitate to refer them to a dentist. The sooner the patients seek care, the better their chances of preventing damage. And just a summary of me, I'm a graduate of Spelman College and the University of Iowa College of Dentistry, a member of different professional organizations, and I love to do community involvement. It's a great way to meet the patients, to see what patients are interested in learning about, and to help direct patients in different avenues, whether they need to go to a physician or a dentist. And some of the things that I'm involved with specifically are volunteering on different vans, different mobile vans that go to different communities. So I do one for children, and that's with Colgate. And then I also do one with the Baptist Mobile Dental Clinic. And when I'm on the dental vans, I'm not necessarily treating periodontal disease, but if I see signs of periodontal disease or any other things that don't look normal, I refer patients to clinicians in their area so that they can seek care. My office is located in Lithonia, Georgia, and the name of it is Family Dentistry at Stonecrest.